In case 1, a 62-year-old white male was referred to the Mayo Clinic for consideration of autologous hematopoietic SCT for progressive hepatic and cardiac kappa light chain AL. A year prior to referral, he was diagnosed with International Staging System Stage 3 immunoglobulin G kappa multiple myeloma, 50% plasmacytosis, calcium, 15.3 mg/dl, beta-2 microglobulin, 9.1 mg/L, creatinine, 2.1 mg/dl, with vertebral fractures. After discontinuing a trial of lenalidomide because of severe skin toxicity, he achieved a brief partial remission following 8 months of cyclophosphamide, bortezomib, and dexamethasone therapy. Prior to presenting to the clinic, he developed rapidly progressive hepatomegaly. Alkaline phosphatase was 422 U/L, and a liver biopsy demonstrated extensive amyloid deposition. Cardiac involvement was confirmed with magnetic resonance imaging with an interventricular septal thickness of 16 mm. Brain natriuretic peptide was 1483 pg/ml, and cardiac troponin T was 0.08 ng/ml. The patient underwent reduced dose melphalan conditioning, 100 mg per square meter, and autologous stem cell rescue. SCT was uneventful. However, he did not achieve a very good partial response, and at day 100, treatment with carfilzomib, cyclophosphamide, and dexamethasone was started. After 9 months of therapy, cyclophosphamide was stopped as the light chain level plateaued after achieving very good partial response and the patient developed progressive anemia. In December 2014, he developed biochemical progression, and cyclophosphamide was added with an initial response for 6 months that was followed by rapid progression and clinical deterioration, December 2015. He developed rectal bleeding because of friable hemorrhoids and mucosal vascular involvement with amyloid. He required multiple hospitalizations for congestive heart failure and multiple surgical interventions to control rectal bleeding resulting in transfusion-dependent anemia. Daratumumab treatment was initiated as per the U.S. prescribing information with the first dose given as an inpatient, which he tolerated well. At the conclusion of 8 weekly treatments, there was improvement in his performance status and the bleeding subsided resulting in transfusion independence. It was the first time in 4 years of illness that he achieved normalization of serum-free light chains, figure 1. NT-proBNP went from 2882 pg/ml to 3568 pg/ml, and cardiac troponin T declined from 0.05 ng/ml to 0.01 ng/ml. Alkaline phosphatase increased mildly, but liver size remained stable. In case 2, a 55-year-old white male was diagnosed with lambda light chain amyloidosis as he presented with unexplained nephrotic syndrome with more than 10 g/d albuminuria. He was treated with 8 months of cyclophosphamide, bortezomib, and dexamethasone. At baseline, he had 15% marrow involvement by lambda-restricted plasma cells. He responded well to treatment, data not available, but it was discontinued because of severe peripheral neuropathy. His proteinuria progressed over the course of 6 to 8 months, and he presented to the Mayo Clinic. After extensive evaluation, high-dose therapy and SCT were recommended for lambda light chain AL with kidney involvement and progressive proteinuria. The patient tolerated high-dose melphalan, 200 mg per square meter, well except for fluid overload associated with stem cell mobilization. He achieved partial response, 50% reduction in lambda light chain, after SCT. 6 months after transplant, he developed increasing proteinuria and lambda light chains increased. Salvage treatment with carfilzomib, cyclophosphamide, and dexamethasone was initiated. After 6 months of therapy, he developed progressive disease and worsening peripheral neuropathy. At this time, treatment with daratumumab was started. After 12 weeks of treatment, the patient reported significant improvement in quality of life with improvement in renal function. Serum creatinine decreased from 3.1 mg/dl to 2.0 mg/dl, and edema, serum albumin increased from 1.6 mg/dl to 2.3 mg/dl. He achieved hematologic complete remission, figure 2. He developed a mild infusion reaction, burning sensation in eye and scratchy feeling in throat, with the first infusion that was given over 15 hours, but each subsequent infusion was shorter, most recently 3 to 4 hours.